Good evening, everybody. We, Believers Church Medical College Hospital, Thiruvalla, Kerala, we're extremely happy and we're extremely proud to be able to bring to you this webinar on updates in the management of Gram Negative Sepsis, a clinical pharmacist perspective. Let me welcome everyone who's logged on to the session. We've had over 1,300 registrations and overwhelming response. Thank you, everybody. We will provide online certificates to all the registered participants. For this webinar, we have a very dynamic moderator, and she's going to be backed by 4 panelists, all experts in their own respective fields. So let me just introduce the moderator, Dr. Jayalakshmi. Ma'am is Professor, Department of Microbiology at PhD Institute of Medical Sciences and Research at Coimbatore. She is a renowned teacher, a researcher, an NABH and NABL assessor, and certified implementer of JCI standards. Welcome, Dr. Jayalakshmi. Let's go over to the panelists. The first panelist is Dr. Jency Maria Koshy, Professor, Department of General Medicine at Believers Church Medical College, Thiruvalla. With her training in infectious diseases, she focuses on tropical medicine, neuroinfections, and HIV medicine. Welcome, Dr. Jency. Welcome, Dr. Joseph John, who is Assistant Professor, Department of General Medicine at Believers Church Medical College Hospital, Thiruvalla. He's a clinical head of the Intensive Care Unit at PCMCH. Welcome, sir.
Thank you.
May I also welcome Dr. Mohammed Hisham, who is an American board certified critical care pharmacist. He's a researcher. He currently works at Cleveland Clinic of Dhabi. Thank you, Mr. Hisham. Thank you for joining us. Our next panelist is Dr. Grace Mary John, clinical specialist and clinical pharmacy coordinator with special training in infectious diseases and antimicrobial stewardship. That is our moderator and the 4 panelists. Let me hand over to the moderator for the evening, Dr. Jayalakshmi. Over to you, ma'am.
Thanks, Dr. Sumita. Good evening, friends. It's nice to have a very good response from all of the clinical pharmacists. That only shows how much you're interested to update your knowledge into this current requirement of knowing your antibiotics and understanding them very well and using them as effectively as you need to, and so that you prevent misuse at every other end. Okay, and we know that the role of the clinical pharmacist is crucial in a team that treats the patient. And the most sick is in the ICU. And we say that the sepsis patients are the ones who require the immediate care. And if they're not attended to immediately, then they would have very fatal end, which could be death by itself. So it is very important that we understand the basics and also the current magnitude of this problem globally as well as in the Indian scenario. So I invite Dr. Joseph John to give his thoughts about sepsis and his clinical guidance on his practical guidance that he would give through this entire process would be very, very useful for all of us in understanding why this is important. Over to you, sir.
Thank you, ma'am. And a very warm good evening to all of you. Before we move further into the treatment and the other aspects of gram-negative sepsis, we have to know what is exactly sepsis. Since the early 1990s, when the definitions were provided by Bourne et al., which included systemic inflammatory response syndrome, we have come across with further evolution in the sepsis 3 guidelines to a newer definition of sepsis. So initially, systemic inflammatory response syndrome plus infection constituted sepsis. However, one should know what systemic inflammatory response is in the first place. The criteria of temperature more than 38 degrees centigrade or less than 36 degrees centigrade, a heart rate of over 90 per minute, a respiratory rate of more than 20 per minute, or a partial pressure of arterial carbon dioxide less than 32, and a white cell count of less than 4,000 or more than 12,000. Any 2 of these criteria, if they were positive, it meant sepsis was to be considered. But the drawback of this definition was that systemic inflammatory response syndrome was seen in causes other than sepsis, like a clean trauma or surgery. So in sepsis 3 guidelines, the International Sepsis Consensus Conference, or sepsis 3, defines sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So from infection, we have now come to define sepsis as a dysregulated host response, which is responsible for multi-organ dysfunction. So the initial definition of severe sepsis, which was systemic inflammatory response causing multi-organ dysfunction, now and we now have the systemic inflammatory response syndrome, which is rather superfluous with the current definition of sepsis. In sepsis, the whole the whole idea of systemic inflammatory response syndrome comes in the very definition of sepsis. So now we have sepsis and a subset of sepsis, which is called the septic shock, which which is defined as a hypoperfusion and associated with circulatory failure, cellular dysfunction, and metabolic dysfunction. Sepsis 3 guidelines mention that the SOFA score, an increase of 2 or more noted, denotes a multi-organ dysfunction. Now, what is a SOFA score? We have 6 systems which are assessed, starting from the central nervous system, the respiratory system, the coagulation system, the hepatic system, the cardiovascular system, and the renal system. And a grading of 0 to 4 is given. At the least, you have 0, and at the maximum, you have a point of 24. So a higher score, it means a worse prognosis and a higher mortality. This is very important in assessment with a quick SOFA. We have also the quick SOFA, which can be used at the bedside to assess whether the person is or is or has a possibility of multi-organ dysfunction due to sepsis. This includes 3 criteria: whether the mentation is altered, number 2, whether the respiratory rate is more than 20 per minute, 22 per minute, and a blood pressure of 100 millimeters systolic or lower. A point 1 is given for any of these which are positive, and 2 points or above means that the person is most likely to have a multi-organ dysfunction for which one of the causes could apparently be sepsis. Now, what are the limitations of SOFA and quick SOFA? These were primarily designed as research tools at a population level to predict mortality. They do not define sepsis. The clinical deterioration which can be found in any patient can be on account of causes other than sepsis. So sepsis is just one of the causes that needs to be excluded in a patient in whom you have an increasing SOFA score. But remember that SOFA, the QSOFA, the quick SOFA is not a very sensitive tool. It has only 60.8% sensitivity and a moderate specificity of 72%, coming way behind the SIRS and the National Early Warning Score in terms of sensitivity. Now, as far as sepsis is concerned, what is the global scenario? In 2017, in the global burden of disease estimates, there were 48.9 million global cases of sepsis, causing 11 million deaths. Daily, around 1,400 individuals expired of sepsis or septic shock. Remember that in those that recovered, there were lifelong disabilities, cognitive decline, functional decline, and there were psychiatric problems as depression. They were more prone to rehospitalization and mortality was enhanced in them. The incidence of sepsis is more in the lower socioeconomic and the middle socio-demographic countries, and it abounds more in females, and children are also affected to the tune of almost 40%. Here you find in the Global Burden of Disease study that the distribution of sepsis, which is seen mostly in the sub-Saharan Africa, South Asia, and the South Pacific islands. So also you find an increased mortality in these areas, that is in sub-Saharan Africa, South Asia, as well as in the Asia Pacific region. Next slide, please. The next slide, please. Now, about sepsis in India, we have very limited data because epidemiology studies in India describe more, they are more an epidemiology of the infection rather than sepsis. Most epidemiological data still are from the West. What we know from India is a high mortality, especially in the ICUs. 1 in 4 patients in the ICUs develop sepsis. The commonest cause of death in the ICUs is sepsis, and the overall mortality, sepsis contributes is the 11th in number. Survivors, as earlier mentioned, have a poor quality of life. Some of the studies from a tertiary medical center over a 5-year period, which came in the Indian Journal of Critical Care, showed that 282 of the 4,711 admissions over a 5-year period were patients with severe sepsis. The ICU mortality was exceedingly high at 56%, while the hospital mortality in these patients amounted to 63.6. So you can understand here the extent of the disease burden and what a strain it is to families and to institutions that care for these patients. The median Apache score 2 on admission was 22, which is quite high. The higher the Apache score, the greater the mortality. The median hospital length of stay was quite prolonged at 8 days. Next slide, please. In a 5-year data from this same study, it was found that gram-negative organisms were more predominant to the tune of 73%. The total microbiological documentation was available in 172 patients. That is 61% of the total number of patients studied. And what were the organisms? Amongst the gram-negative, we had the Acinetobacter baumannii at 21.2% and Pseudomonas aeruginosa at 17%. Klebsiella and E. coli and Enterobacter were to tune of 15.4% and 3.3% respectively. The site of infection which was most commonly involved was the respiratory tract at 55.3%. Intra-abdominal infections were 14.9%, bloodstream infections 14.3%, and UTI at around 13%, followed by skin infections at 1.3%. Over to the next panelist.
Yes.
Thank you very much.
Dr. Joseph, thank you very much for taking us through the entire of your clinical scenarios in the sepsis, and you're taking us to the global and the Indian conditions as of now, the burden of the disease itself, the mortality and morbidity it takes along with it. And now it is very important to know that why is this gram-negative more serious than the gram-positive itself? In the sepsis scenario, because you said in the last 5 years, you've seen more gram-negatives than the gram-positives itself. And how important is it to diagnose these infections early so that you treat them early so that they become more relevant in handling these patients better? So importance of knowing a gram-negative sepsis and why a gram-negative sepsis precedes a gram-positive organism sepsis, and how do you identify them, and what are the various diagnostic tools that we have. So this would be discussed by the ID physician, Dr. Jency. Before that, I would like to tell the participants it's an overwhelming response that we've had so far, but we would love to hear your comments. Please put it up in the chat box. We will put it up for the panelists to answer your queries and questions. So whatever queries and questions you have, you please put it up in the chat box, which is seen on your screens, and we will take up these questions together at the end of the sessions. I'm sure you have many, right? Thank you very much. Over to Jency for your presentation on why gram negative and also the diagnostic tools that are available in identifying them early. Thank you very much.
Thank you, ma'am, and a very good evening to all our participants. So yeah, like rightly said, though sepsis can be caused by bacteria, fungus, virus, or rickettsial, in our clinical practice, what we encounter most is a gram-negative sepsis. But how does it differ from others? Let's look at the structure of the bacteria first. If you notice, the gram-negative bacteria have outer membrane, periplasmic space, high levels of lipopolysaccharides and lipids and porins. This makes them more resistant to antibiotics. So also if you notice, they have endotoxins in addition to exotoxins, making them more virulent. So the development of antimicrobial resistance is a major hurdle while managing these patients. And in-depth knowledge of this would be vital in instituting an optimal therapy for these patients. But looking at the resistance, next slide, the bacteria can have both intrinsic or acquired resistance. Now, what is intrinsic resistance? That means these bacteria are inherently resistant to certain set of antibiotics. If you look at the next two slides, you would notice that these are some of the common antibiotics. The next slide, we can see the common antibiotics which we use for gram-negative infections, like ampicillin. They are resistant to Klebsiella. So, if you know these are the organisms we are dealing with, we should not be using it. If you look at the non-enterobacteriaceae in the next slide. If you look at Acinetobacter, they are resistant to ampicillin, amoxiclav, ertapenem. And so we should not be using this. Pseudomonas, they have a wide range of resistance in Pseudomonas. So this is important when the microbiologists give us the report, and we know that these are the organisms which are isolated and we are still awaiting the antimicrobial susceptibility. If the patient is on any of these antibiotics, we should be sort of taking it off and use an antibiotic which is effective for that particular bug. So that is what is important here. Now, looking at the acquired resistance, what are the mechanisms? There are four main mechanisms. One is by limiting the uptake of the drug. Next is modifying a drug target. Most of the antibiotics, they have a particular way of entering the microbes. But if the microbe alters the target, the antibiotic can't enter the microbe. Inactivating a drug is another mechanism. So this can happen by using various enzymes which is produced by the microbes. The other is they sort of throw out the antibiotic which comes in by using active drug efflux. Now, let's look at the way, this is something which we are really worried about, the various drug resistance. So just for definition, what are MDRs, what are XDR, what are PDRs? We call MDR when they are non-susceptible to more than one agent in more than 3 antimicrobial categories. We call them XDR if they are non-susceptible to more than one agent in all but less than 2 categories. And we call them PDR when they are non-susceptible to literally all antimicrobial agents. And when we look at the resistance to the various group of antibiotics, what we are usually concerned are the fluoroquinolones, the aminoglycosides, beta-lactams, including the carbapenems, and the polymyxin. The resistance to fluoroquinolone and the polymyxin are usually attributed to chromosomal mutation. In addition, in polymyxin, you can have a plasmid encoded resistance. But we know that in clinical practice, what we usually use is the beta-lactams and the beta-lactam inhibitors. So to understand this, we would look at the beta-lactamases. So if you see at the into the next slide, the beta-lactamases can be divided as the whether they are serine-based or whether they are the metallo-beta-lactamases. So when we are dealing with this, we have to worry, when are we going to deal with these cases? So this depends on the risk of the patients. So these are patients with previous antibiotic therapy, recent hospital stay, prolonged length of stay, recent colonization, or extremes of age, or if they have other comorbidities or immunocompromised. And especially if it's a urosepsis, it may be someone with the indwelling catheter for a long time. If they have a pneumonia, it may be a patient who's on ventilator for a long time. So that should be in our back of mind when we are dealing with these cases. So moving on to the beta-lactamases, um, uh, we would look at the various classes according to the AMBER classification. So the serine-based one are the class A, C, and D in the AMBER classification, and the metallo-beta-lactamases are the class B. The next slide looks a little crowded, but I would try to make it as simple as possible. So what is our concern are three main beta-lactamases. One is the ESBL, the other is the AMCs, and the third one is the carbapenemases. Looking at ESBLs, they are the serine-based. Now you look at the class A, the first panel, they are the class A beta-lactamases. Now, the ESBLs are evolved by mutations in genes encoding beta-lactamases TEM1, SHP1, and also CTXMN. Now, what is the significance of this? Because they can be blocked by clavulinate, sulbactam, or tazobactam. So we know that ESBLs, we can use these antibiotics. But there's a caveat to it. If you have TEM-derived ESBLs, they can acquire resistance even to clavulanic acid and sulbactam, but not tazobactam. So in that case, you may not be able to use beta-lactamase inhibitors like clavulanic acid or sulbactam. You have to use a tazobactam. But tazobactam has a problem with inoculum effect. That means if there is a higher inoculum of the organism, then even this tazobactam may not be effective. And in that case, we may have to introduce a carbapenems. Now moving on to AMCs, that is the class C. Now AMC is again a serine-based beta-lactamase. Here they mediate resistance to penicillins, cephalosporins, cefamycin, aztreonam, and so also beta-lactamase inhibitors like clavulanic acid, sulbactam also. So that means you can't use any of these drugs while treating these patients. Tazobactam is a moderate inhibitor of AMC enzymes. But you should remember here, you see the depressed AMC. So some inhibitor activity is reduced against strains with totally depressed AMC beta lactamase. So in those cases, we may not be able to use even tazobactam. So in this case, avibactam, the newer one which has come up, which is in combination with ceftolozone or ceftazidime, can be an option here. Now the last one, which is the carbapenemases, is the most dreaded one. Carbapenemases, if you look, if it's in the class A, right at the bottom line, if you see, they are the in the class A, the Klebsiella pneumoniae, or in the class D, if you see the oxacarbapenemases, and the most notorious one in the class B, they are the metallo-beta-lactamases, which are the Verona integron encoded metallo-beta-lactamase, New Delhi beta-lactamase, and the imipenemase. So here what the problem is, they resistant to cephalosporins, cefamycins, all the beta-lactam inhibitors which we talked about, that is clavulanic acid, tazobactam, sulbactam, and even carbapenems. So that means we can't use any of these drugs when you're dealing with the carbapenemases. One catch is aztreonam is stable, though it's not effective against AMC, it has some effect against the metallo-beta-lactamases. So that is NDM, which we are worried about. There you can use aztreonam. But otherwise, the only drug left is colistin and tigecycline for these cases. So knowledge of these resistance mechanism is very crucial while making a decision regarding which antibiotic to institute. Now, moving on to the other part of diagnostics. See, Dr. Joseph John rightly pointed out when will we think of sepsis and where the various guidelines given. But when you actually see them in ER, what are you going to do? There is a suspicion of sepsis, but how fast there's no point of care test where the patient walks into the ER and you can just do that test and say, okay, this patient has sepsis. So what can we do? What do we have in our hand? So conventionally, what happens is if a patient comes into our emergency room, we are going to send, first, definitely we would take a history and clinical examination and sort of decide which organ is affected and if this patient has sepsis, and then send these investigations, hemogram, renal and liver function test, coagulation profile, blood gases, and cultures. One thing I would like to stress upon about the culture is this is something which is very important, especially before giving the first dose of antibiotics. And when you send cultures, you should send enough blood because unless the inoculum is sufficient, the lab would not be able to isolate it. So ideally, we say 2 sets of cultures to be sent. Now, this is what we usually do, but is there something more which we have in hand? So that's where the role of biomarkers come in. To understand this, let's look at the inflammatory mechanism in sepsis. So the inflammatory response is initiated by detection of the invading pathogens. So they have 2 main receptors, that is the toll-like receptors, TLRs, and the NOD-like receptors, NODs. So the TLRs are extracellular and the NODs are the intracellular one. So they can have the molecular pattern from pathogens, that's the PAMPs, and the damage associated molecular patterns from the endogenous cells. So these are identified by them. So the TLRs will identify the DAMs and they propagate an inflammatory response as shown here. And the nodes also, if they go into the cytosol, then the nodes will further help in the production of the inflammatory cytokines. So if you look at the next slide, we'll try and understand this slide. If you see the middle panel, you will see the various cascade which are set into action. That is the complement system, coagulation system, vascular and tissue cells, and the blood and lymphatic cells. So when these systems are activated, they are going to set in a whole lot of mediators which are going to come into play. So the importance of this is we are going to use these markers to diagnose sepsis. So let's briefly look at these markers. First one is CRP. CRP has probably been the most widely measured acute phase reactant that is coming from the vascular and the tissue compartment. They are both pro-inflammatory and anti-inflammatory. If you look at procalcitonin in the same group, this has achieved much trigger in the last 1 decade. But what is the role of procalcitonin? Okay, it has some role in telling maybe we are dealing with sepsis, but we know that they can be high in other inflammation as well. But once the patient is on treatment, if they are responding, the procalcitonin comes down. So actually its role is helping us in deciding, okay, this patient's infection is under control and it's time to take off the antibiotic or de-escalate them. Now moving on to interleukin 6. Interleukin 6 is coming again from both the coagulation pathway and the complement pathway and from the vascular system. And it's induced by the primary cytokines of sepsis, tumor necrosis factor. But this can go up within 2 hours of when the patient is going into sepsis. The next marker is the STREM1. This is the triggering receptor expressed on the myeloid cells, which is upregulated on the phagocytes. So this is coming from the phagocytes. And during sepsis, the activated phagocytes release this soluble form of TREM. So that is the STREM1. Presepsin is another marker that is elevated in response to bacterial infection, and that is seen where the PAMPs. So this plays a role in recognition, right on top where the PAMPs are coming in, where the molecular pattern from pathogens. So they play a role in recognition of PAMs. So also CD64, again, it's an IgG binding receptor expressed from the neutrophils, monocytes, all the blood cells, macrophages in response to the cytokines. The last one we have mentioned here as a biomarker is the LBP, that is the lipopolysaccharide binding protein. If you remember in my initial slide, when I talked about the difference between the gram positives and negatives, we told the gram negative bacteria have high content of lipopolysaccharide. So this is an acute phase reactant which binds to the lipopolysaccharide of gram-negative bacteria, and their levels go up in sepsis. The other markers which I have put down here is the neutrophil to lymphocyte ratio and lactate. They are not technically biomarkers, but these are also something which we can use. Neutrophil to lymphocyte ratio, you can assess from your differential counts which comes in the hemogram, and lactate, we can look at the blood gases when they come. Now, having looked at all these biomarkers, they are still going to tell us you are dealing with sepsis. But the gold standard still is pinning down the organism which is causing the sepsis, and that has to be done by a microbiological diagnosis. So in conventional microbiological diagnosis, what we do is first inoculate the patient's blood into a liquid medium, then subculture it. The microbiologist will use various biochemical tests to identify them and put an antimicrobial susceptibility testing and churn out the reports. So, but the problem with this is going to take some time. We have a patient who's sick in ICU with multi-organ dysfunction. We can't wait for this entire scenario to finish to decide on our antibiotics. So that's where the role of empirical antibiotics come. But there are some things which have come up in microbiology which have sort of hastened this process. So if you look at this chart where you see the gray panels, that is what we are conventionally doing. So if you look at right at the center, most of the hospitals now have the automated systems like BACTEC. You put them in the BACTEC, it will flag a signal saying, okay, some bacteria has grown. And then the microbiologist will take out and put a gram staining. Even this step is very vital because we know that if it is a gram negative, and in your empirical therapy, if you have put in a cover for MRS assay, vancomycin or teicoplanin, if they say gram negative, you should just take it off because you know you're not dealing with a gram positive and you're dealing with a gram negative. So even that step is vital in our decision making. Further on, they would put it on solid growth media and give antibiotic sensitivity. But the advent of nucleic acid amplification test in the form of PCRs and the mass spectrometry techniques have revolutionized the pathogen identification. So if you see this flag, when the blood bottle flags and say there is a culture growing, you can take that and do a genome sequencing on that and actually identify the pathogen within 1 to 4 hours. There, you would have had to wait another 2 hours to 2 days to realize which organism we are dealing with. So also the same thing can be done with the mass spectrometry technique using Maldi-TOF. So that also is going to give you a report within minutes. Okay, so also in some certain centers, they have done this DNA detection testing on the whole blood. That is right when the day when the patient is coming, they take the whole blood and run a PCR on that and give a report within 4 to 6 hours. So that is really wonderful that we can identify the organism that early and give a optimal therapy right from the beginning. The other modification which has come is the expert carber. You remember when we talked about the various enzymes, ESBLs, AMCs, and carbaphenamases, we told about the notorious enzymes of carbaphenamases, that is the KPCs, NDM, VIM, oxanim. What expert carber does is they can actually identify these genes. So once you identify these genes, you can sort of pinpoint that, okay, this is this particular organism with this particular gene. And we learn that which all antibiotics are going to be effective in these particular cases. So that is the benefit of having an expert carber. So the modern microbiological diagnosis of bloodstream infection is moving really close to the time of clinical suspicion of the presence of infection. Ma'am, would you like to highlight something? Because she is the famous microbiologist with us.
Thanks, Dr. Jency. we will just go ahead and we will take up questions in the future as well. Now, moving on with Grace. I understand.
Yes, ma'am.
It's very, very important that the role of the clinical pharmacist is crucial. Okay, you need to have a qualified and trained clinical pharmacist who are very important into the health system as of now, because they have a very significant impact in the appropriateness of use of antibiotics in developing countries like ours, though this is just one of the other methods of reducing antimicrobial resistance itself. But the role of clinical pharmacist is very, very crucial. And we have an excellent clinical pharmacist today who will share with you on the antibiotics itself and see what is the antibiotic that you have and what is the spectrum of its activity and the PKPDs of them. So over to you, Grace.
Thank you so much, Jency, ma'am. So in sepsis, choosing the right antibiotic at the earliest possible time is the mantra for treating sepsis at the earliest. So as Dr. Joseph John has already told us, the first factor that is for treating to come to an empirical therapy, we need to keep in our mind the certain parameters, like the certain factors before choosing the right one. Because if we don't start the antibiotic right at the right time, with each hour we are increasing in the mortality rate of about 7%. So the first thing, as Dr. Joseph Search told, is that we need to identify whether our patient is really infected. So through his lecture, he took us like how to identify the patient. The next one would be the healthcare associated risk, whether the patient will be having. So Jency ma'am told that the certain parameters that we need to look at to make sure that whether this patient is at a risk of a multi-drug resistant organism or not. The third one is one of the most important one is that is to identify the source of infection. The reason why we need identifying the source is because then we know that which organism we should target. So the general rule is that above the abdomen, you have gram positive predominance, and below the abdomen, we have the gram negatives coming up. So whenever as a clinical pharmacist, when you're going for rounds, when you suspect sepsis in your patient, the first question you should ask yourself is, where is the source? So once you know the source, as Dr. Joseph John has already portrayed, the most common source would be the respiratory as per Indian data, and also followed by the intra-abdominal and the urinary tract, especially in the elderly. Now you know your source, you know which organisms are going to be there. The next one would be like which antibiotic, the right antibiotic that will cover these organisms that you have, your top 5 organisms that is going to cause the sepsis. So for an example, so as a clinical pharmacist, knowing your spectrum is like the most important thing you need to. So next slide, I'll be sharing with you a document which I personally had with me throughout my internship, which actually helped me in understanding the bug-drug interaction. Ma'am, can I have the next slide, ma'am? So you can see this is like a very brief but a very well portrayed classification of bug-drug action. So why do you need to know the spectrum? So I'll just get an example for this. You know that piperacillin tazobactam and meropenem are both very broad spectrum, but you will be startled to know that piperacillin tazobactam is actually much more broader than meropenem in some sort. Because, for example, ma'am, can I have the next one? I have an animation. So if you see the enterococcal coverage of meropenem doesn't cover enterococcus at all. But if you see imipenem covers, and piperacillin tazobactam actually covers the enterococcus fecalis, not the faecium. Faecium beta-lactams normally don't cover much. So when you use for an intra-abdominal infection, that is one of the reasons why we prefer to choose imipenem over meropenem, because the abdomen is one area where you need the enterococcal coverage. So you should know your spectrum, otherwise you cannot go further with your antimicrobial stewardship. So the other one, the next factor would be the patient-specific factors. So when you take a patient, what are the things that you are going to look for in the patient to identify the right antibiotic choice? So I'll give you a few examples. Like let's say you have a very elderly patient who's having kind of diabetic nephropathy and all, and who is at the verge of developing an acute kidney injury. And when you have such a patient with sepsis, and if it turns out that the patient is having a pseudomonal infection, you're already treating with meropenem and you want to give it as a combination. You cannot choose an aminoglycoside because it literally pushes the patient into an acute kidney injury. But you can go ahead with the fluoroquinolone. The other one example that I can give that you should have in mind is the when you choose an antibiotic, what are the possible collateral damage that can happen while choosing an antibiotic? For example, in an elderly patient, if you with the cardiac issue, you will have some. If you choose a fluoroquinolone, you will have problems with QT prolongation, cardiac conduction defects. You will have tendonitis, C. diff infection. So considering all this and like what are the patient specific factors, you need to choose an antibiotic for your patient. And the other one, like I've just talked about the patient specific factors. Now the drug specific factors, that is the pharmacokinetics and dynamics. So as a clinical pharmacist, I would advise my fellow clinical pharmacists, and I've always told this, that as a clinical pharmacist, our major expertise comes with this pharmacodynamics and pharmacokinetics. So kinetics, it's ADMA. The reason why you should know your pharmacokinetics very strongly is that so that especially when it comes to antibiotics, it's majorly the distribution. For an example, how about tigecycline for sepsis? You've not seen tigecycline monotherapy anywhere for sepsis, right? It's only as an adjuvant to some other antibiotic that's already going. So the reason why it is like that is because tigecycline has a very large volume of distribution. So once you give the drug into the body, it just goes all across the place, all across your body, such that there's not much left in the blood to treat the organism for sepsis. The other example that I can give you is when you have a cirrhosis patient with ascites, and let's say the culture report came out and it is showing that it's a non-ESBL producing E. coli. It's a very treatable E. coli. And your gastroenterologist want to prefer giving a third generation cephalosporin. And you have two choices. Let me give you two choices, the ceftriaxone or the cefotaxime. Which one would you choose? Now, ceftriaxone, the concentration that it attains in ascitic fluid, is only 50%. But when it comes to cefotaxime, it attains up to 120%. That is more than even in blood. So you choose cefotaxime for SBP rather than ceftriaxone based on the kinetics. Now, coming to the pharmacodynamics of PKPD of antibiotics, you can broadly classify antibiotics into two major categories. That is the time-dependent and the concentration-dependent antibiotic. So in the time-dependent antibiotic, mainly all the beta-lactam comes in that category. So when you plot time versus concentration, the X and Y axis, you can see that green dotted line is the minimum inhibitory concentration, MIC. So our job is to keep the time that we are exposing the bacteria to this antibiotic above the MIC to the maximum. So for these time-dependent beta-lactam antibiotics, it's the time that matters. So for us, the peak, we don't have to worry about the peak. So instead of giving it like 2 times a day, if you can give it 4 times a day, it would be better. One strategy of doing that is to give it over as a prolonged infusion or a continuous infusion. That's why you can see meropenem right now, meropenem, piperacillin, tazobactam, all are being recommended to be used at 3 to 4 hours. For meropenem, it's 3, peptides, we can go up to 4 hours because the time that drug spends above the MIC will be more and thus ensuring more killing of the organism. But towards the concentration dependent antibiotic, it's just the opposite. For them, the concentration matters. Time above MIC doesn't matter. The reason why they are like that is because if you see these antibiotics like aminoglycosides, the fluoroquinolones, all these antibiotics, they target, their mechanism of action mainly is the protein synthesis. So once they inhibit the proteins, the organism will need time to synthesize new proteins. So by the time our immunity takes care, right? That is a bacteriostatic bacterio this thing. So by the time they produce new proteins, if you give a high concentration, it makes sure that that more organisms are being inhibited by these uh, concentration. Therefore, you can actually, instead of giving it infrequently, you can give it like once a day or twice a day. Earlier, when I was doing my internship, I used to see colistin like 3 million units QAH. Now I don't see 3 million QAH. It's mostly 4.5 Q12H. It's majorly because it's a combination of this concentration dependent activity. And when it comes to a patient, when you see a patient, the pharmacokinetic consideration, because patient is sick. When you have a patient with sepsis, that patient is quite sick, and the physiological thing, it goes mayhem actually. And I want all the clinical pharmacists to concentrate on third point there, the augmented renal clearance, because this is something that I've noticed that many of us kind of goes away from the target. So when you have a patient with sepsis, initially when they develop sepsis, because of the high cardiac output, the kidney actually clears the drug very easily. So if when you see a patient who comes to the ER with a full-blown sepsis, and if the patient is having good urine output, and even if your creatinine is, let's say, 2 to 0.5, don't change the dose. Instead, give them maximum as possible. You give them the maximum dose. Because meropenem, you can give a 2 gram bolus dose followed by 1 gram TDS. But if you actually, instead of giving the full dose, if you reduce that, the kidney is going to throw away all of that, and you won't have enough drug to combat the organism that you have. So when you have a patient in initial sepsis, always give the maximum possible dose. And only when the patient's urine output comes down to less than, let's say, 30 milliliter per hour, at that time you think of reducing the dose. But as much as possible, always give the higher dose, so that we don't want a therapeutic failure because of low drug levels in the body. So with all this, I can now come to the empirical choices, the common choices. This is like the practical thing that we've been following in our hospital. So based on a patient, let's say you have a patient who is not in shock, the BP and all it's stable, just that they have, the initial SIRS criteria. You want to give those patients a broad spectrum antibiotic which will cover the ESBL. You always have to cover ESBL in India because our rates of ESBL are quite high. It's about 70 to 80%. So there's no way we cannot cover for ESBL. So your choices would be like the BLIs, including the piperacillin tazobactam, the cephalosporin sulbactam, the carbapenems. And if your institution is having a good sensitivity to cefepime, you can use. But our institution, the rates of cefepime sensitivity is less than 40%. So we don't recommend cefepime, but we go for these choices. But if you have a patient who is having a hypotensive event, who is in shock, don't think twice. You have to give carbapenem. So you have to hit hard at the right time. And based on the risk the patient has, you can choose whether you need to add on an MRSA cover, like a recent surgery the patient underwent, or whether the patient has an intra-abdominal or something for which we need to cover the pseudomonal, like as a combination to what we are already giving. Okay. And for septic shock, don't think twice. It's a carbapenem. And for a patient who is already in the hospital, in the ICU, or quite sick, getting more sicker, and if your institution is saying that the CRO rates for this patient is quite high, you can, along with carbapenem, it's maybe advisable to choose colistin for these patients. So these are the empirical choices that we normally say, and always make sure your based on your source of infection, you cover for the other one. This is based on gram-negative sepsis. What I'm saying is you have to cover for the respective sources also, the most common organisms also you'll have to. So once you get your definitive culture, the culture which shows that this is my organism, then you have to de-escalate or do things based on that. Now, the general thing that we all do is that if you have a patient with ESBL, but without a bacteremia, let's say for an example, there was a patient with urosepsis, the urine culture is showing ESBL E. coli, but there's no culture in the bacteremia. You can bring down from the carbapenem to BLBLI, and uh, you can alternatively you can use carbapenem, but it's always good to spare them. And but if you have a patient with a bacteremia, a ESBL bacteremia, don't think twice. You cannot de-escalate. You have to go ahead with carbapenem. So ideally, we can use ertapenem if it's like E. coli or Klebsiella. If it's sensitive, you can go for ertapenem because ertapenem will not cover Acinetobacter or Pseudomonas. So we are in a way shortening narrowing the spectrum, but we are treating them adequately. And if you have an AMC producer like the spice organisms, Serratia, Proteus, indole producing Pseudomonas, Acinetobacter, Citrobacter, Enterobacter, these are the organisms which initially will show like piperacillin Acinetobacter sensitive, Cephalosporin sensitive in the culture report. But for the first few days, they will actually get better. But during treatment, they tend to, grow resistant to these drugs, and hence it is advised to give carbapenem in the first place itself for these organisms. Now, our biggest threat, our biggest nuisance is the carbapenem-resistant bugs. So first, I'll discuss about the Enterobacteriaceae. Now, for Enterobacteriaceae, it is advised that you use a combination therapy rather than a monotherapy. Now, you have two strategies to use. The first one is the colistin-based strategy. That means you can add colistin, and along with that, you can, if you want, you can add sulbactam, but that's a very high dose. Sulbactam is nearly 10 to 12 gram per day dose is what is suggested, not 500 mg q6 or phosphomycin or carbapenem. One thing I want to stress here is that if you are using a carbapenem, let's say you are using meropenem, and if the MIC is about 8, okay, normally we have 2, 4 and all, but if your organism is having 8, we recommend a dose of 2 gram TDS rather than 1 gram TDS because those are difficult to treat infections and therefore you need to give a higher dose. But if you're having a meropenem sensitivity, I mean a culture of showing resistant with 64, 128, there's no point giving meropenem there, even if you're using the higher dose. Go for an alternative therapy. And what Jency ma'am has suggested, if you have a CABA expert, then you will be able to make out which resistant mechanism is actually there right now for our patient, for that patient. The other strategy we can use is the colistin sparing, that is using the ceftazidime avibactam estrionum combination because it covers both OXA. The NDM is covered by estrionum and the OXA is covered by the ceftazidime avibactam. But that is according to your institutional protocol. It cannot be used empirically without like the ID approval and all because that's the latest one and we don't want to push it into a resistant one. So for CRE with OXA48, ceftazidime avibactam based therapy is what is recommended because the others normally don't work. If there's colistin, you can use colistin instead of ceftazidime avibactam, but colistin based therapies are more toxic. They're nephrotoxic, neurotoxic. So ceftazidime avibactam would be the best to treat if you are having an OXA48. But if you're having an NDM, you can go for an estrionum based or a colistin based therapy. But recent literatures are showing that when you give estrionum with ceftazidime avibactam for NDM, there are better mortality benefits. So that's again according to your hospital, your ID physician, whether they want to do or not. And coming to the now I've talked about the fermenters. Now coming to the non-fermenters like Pseudomonas and Acinetobacter. For Pseudomonas, if it's a pan-sensitive one, like already these non-fermenters, they are having so much of resistance. They are having so much of intrinsic resistance, as already Jency ma'am had put out that slide. And when you have the Pseudomonas, you can give ceftazidime or cefepime, piperacillin, tazobactam, cephalosporin, sulbactam, or carbapenem. So that again would be based on your local antibiogram, how well your drug works on your bug. And but if let's say, ma'am, can I have the next slide, ma'am? So
Yeah, done.
so the if you have a pseudomonas that is resistant to the first line, like an MDR kind of the carbapenemase kind of pseudomonas, then your options would be colistin and colistin or ceftazidime avibactam. Always remember that ceftazidime avibactam can work quite well for pseudomonas, but not for acinetobacter. That is the difference between pseudomonas and acinetobacter for a resistant carbapenem resistant one. So along with Pseudomonas, you can always choose to have a combination therapy if your physician wants to. And for carbapenem-resistant Acinetobacter baumannii, the first line would always be colistin because that's the only one right now we have that is there to treat. As I told earlier, ceftazidime avibactam will not work, aspirinol will not work, and the alternative agents that are there would be tetracycline and minocycline. So these are the treatment options that we have for the gram-negative bacteria we have in the Indian scenario. Thank you, ma'am.
Thank you. Thank you, Grace, for that excellent presentation. The last three speakers have been giving you an oversight of complete on the sepsis itself, with Dr. Joseph telling you how this sepsis as a syndrome is being characterized by systemic inflammation due to infection with range of illnesses leading to high mortality, and how it is important to understand that every one out of every four patients that come to your ICU may go or develop sepsis, and one in every five deaths in world over would be due to sepsis. So he established the magnitude of this problem, and Dr. Jency brought in with a lot of clarity and brought very clear concept of telling you how gram-negative sepsis is different from gram-positive because of the difference in the morphology itself. The organism is different, the way they produce resistance is different, the type of intrinsic resistance, the acquired resistance was clearly laid upon by Dr. Jency. And she also mentioned the various resistant mechanisms, which included the beta-lactamases, types of beta-lactamases, the ESBLs, the AMCs, carbapenem resistant ones, and the methodologies of diagnosing them as a simple routine conventional methods, as well as those which are used as biomarkers using the key biomarkers that may be used at different points of time. And thanks to Grace for adding these points on the antibiotics that may be useful in treating patients with sepsis depending on the type of organism and the type of resistant, looking into the PK/PD, which is the pharmacokinetics and the dynamics itself. So as clinical pharmacist, you have gone through the entire process in understanding these, but it is important further to know how to monitor these antibiotics which are given into these patients. So for this, I think the clinical expertise of Dr. Joseph is again needed at this point of time. So Joseph, sir, we would love to hear from you on monitoring the antibiotic use in these patients, on the effects of antibiotics in these patients over a period of time of treatment. Sir, can we hear you?
Yes, thank you very much, ma'am. Now that you've got an overall picture as to the antibiotic, to the microbial resistance, why we have to use a broad spectrum antibiotic, I will now take you through some steps which have been earlier spoken to you by Professor Jency. How would you monitor antibiotics, and how would you estimate the clinical outcome in these patients? I would like to be very clear in what investigations you use, and you should have a great deal of common sense when you use these investigations, for they not only tell you about the clinical outcomes. The first thing that you should know is when to send these investigations. Once you've made, with a quick SOFA score of 2 or more, a diagnosis of a probable sepsis, you certainly have to cast a wide net to exclude not only sepsis or to confirm it, a sepsis, but to exclude other causes. So the routine labs like a hemogram, a biochemical investigation like a liver function test, a kidney function test, Not to forget the importance of a blood gas, for it gives you an idea of the partial pressure of arterial oxygen, the fraction of inspired oxygen. And so you can calculate the PF ratio in these individuals, which also you could also have an assessment of the lactate level from the ABG. These parameters will help you later on to check on the SOFA score, the baseline which comes on admission. Leave that apart. That can come a little later. But the most important thing for you would be a microbiological evaluation. That is a blood culture at the appropriate time. Once the patient is triaged in the emergency department, a blood culture along with the routines should be sent within that first hour while you take a good history, or at least a cursory history to know what is the problem, while you secure the airways, while a venous access is being established. All these labs have to be sent. A blood culture is exceedingly important. Now, I shall just quote a study. The importance of blood culture which is sent on time. In a randomized trial of 325 patients with presumed or confirmed sepsis or septic shock, 2 sets of blood cultures were drawn from 2 different sites before antimicrobial administration. A second set of blood cultures were taken at 0 to 4 hours of the antibiotic administration. And it was found that the pre-antimicrobial culture was positive in 31.4% patients, while the post-antimicrobial culture was positive in only 19.4% of the patients. So the blood cultures have to be drawn within that first hour as per the guidance given by the SSC. The second thing that you have to do is to remember later on to take other cultures, which when added to the post-antimicrobial culture gives rise to an identification of pathogen in at least 2/3 of the cases. So the importance here is of taking a blood culture prior to antimicrobial administration. Now, what are the inflammatory markers that Dr. Jency talked to you about? We shall just concentrate on procalcitonin and CRP. What is the diagnostic significance of procalcitonin? The evidence to support this is still not robust. There are various protocols in various centers which use procalcitonin to diagnose patients with suspected infections and who are critically ill, and to provide guidance for introduction of antibiotics in these patients. You should see in the graph that procalcitonin peaks almost 24 hours before the peak of C-reactive protein. And so it gives you valuable time to see that whether you have used the appropriate time, appropriate antibiotics in the appropriate time. Now, the value of procalcitonin comes in de-escalation of antibiotics. It is exceedingly important to note that and to use this test judiciously to guide your treatment. It was found in the study that a procalcitonin reduction by over 90% or a total level of less than 0.25, it indicated a strong requirement that the antibiotics be stopped. If the procalcitonin decline was more than 80% or a level between 0.25 to 0.5, cessation of antibiotics was encouraged. However, if the decline was less than 80%, it meant you had to continue antibiotics. And if the procalcitonin level was exceedingly high, yes, it meant the antibiotic therapy had to be continued. You should remember that procalcitonin is a very expensive test, and therefore you cannot afford to do these patients once in every 2 days. But should you suspect on a SOFA score that the patient is declining, the patient's condition is deteriorating, then you should have to use this test judiciously to see whether you have to escalate the antibiotics before the definitive blood cultures come, to see that a wide spectrum appropriate antibiotic is used at the appropriate time. Next slide, please. Now, the procalcitonin use was found to be very important in reducing the antibiotic use. Here you have on the x-axis the number of days of antibiotics used, and on the y-axis the patient's percentage who are on antibiotics. The red shades are the ones ones are the ones of patients on the procalcitonin arm. At the very initiation, with the use of procalcitonin, antibiotic usage was markedly less than in that of the control arm. And the procalcitonin arm, the number of days of antibiotics was certainly much lesser than in the control. By this technique, almost there was a 2/3 reduction in the antibiotic use. Therefore, the role of procalcitonin in deciding on de-escalation of treatment is very important, and that is something that one should not forget. Next slide, please. Now, I just would like to, before I close, there is the time you have to administer antibiotics is very important. This can be highlighted from a database study of over 50,000 patients quoted by Gregory, Schmidt, and Jess Mandel in the evaluation and management of sepsis and septic shock in adults. There were two groups of patients in whom the surviving sepsis campaign bundle was delivered within the first 3 hours, and the second group in which it took longer to complete the bundle. It was seen that the patients who had completed the bundle in the first 3 hours had a lesser mortality than the others in the patients who could not complete the bundle in the 3-hour time frame. But was it the fluid? Was it the fluid that was resuscitation that was important? No. If the fluid resuscitation was delayed, it meant that there was no increase in mortality. But however, with every hour delay of antibiotic administration, there was noted to be a linear increase in the mortality of the patients in the group that received the bundle exceeding 3 hours. It is also important to make the right choice of the antibiotics. You should remember that in around 32% of the hospitalized patients requiring antibiotics, a wrong selection is made. And in the antibiotics delivered to patients which are not appropriate, in that group, the mortality ranged from 32 to 34%, while in the arm that received the appropriate antibiotics, the mortality was 18%. So the right antibiotics at the appropriate time has to be delivered through the right route. That is very important as you go through the treatment of sepsis, and as you monitor the treatment outcomes through with the SOFA score to note whether there's an improvement. Remember that as you assess the SOFA score, if there is an increase in SOFA score, it means that the mortality of these patients would be more than 50%. If there is a decline in the SOFA score, the mortality would be less than 27%. If the SOFA score remains static, then it means that the mortality rate would be somewhere between 27 to 35%. So the higher the SOFA score, the increased mortality risk. And therefore, you should use these parameters, stick to one of these parameters to assess the improvement, to assess whether you've achieved the goals which are required of the delivering physician towards the patient for that particular condition. And these are delivered at the appropriate time. That would be the gist of what I would have to tell you to take home, as these would be the minimal requirements, and this should be the basic requirements that should stick on to your thoughts. Thank you.
Thank you very much, sir. That was excellent in bringing into the concept of monitoring these antibiotics using the scoring pattern as well as the biomarkers and the cultures in guiding into continuing of the antibiotic or stopping the antibiotic at the right time for the benefit of the patient and also to prevent future development of drug resistance. As we move on, I would like to quote Dr. Tom, who's a CDC director, who said, if we use antibiotics when not needed, we may not have them when they are most needed. Guidance to antimicrobial stewardship is crucial, and the role of a practicing clinical pharmacist is important, and it is very well evidenced in developed countries. And they have demonstrated improved clinical and therapeutic outcomes, and they have also shown a reduced health cost rates. Okay, so these things are very well established, and it is getting stronger into knowing and understanding in the Western world, and slowly getting implemented in our country in most of the hospitals slowly. But it is good to hear from Dr. Hisham, who would share his experience in antimicrobial stewardship with how to develop an antibiogram and to go about in starting up an antimicrobial stewardship program and what are the components. Over to you, Hisham.
Thank you, ma'am. Can I have the next slide, ma'am? Yes. So when we talk about stewardship, it's all about teamwork. It's involving a clinical pharmacist into the team of infectious disease specialists, in which includes microbiologists, the doctors, everyone. So as we go on, let's start with the antibiogram. So what is an antibiogram? An antibiogram is a simple lab report which has bacterial isolates in one side and antibiotics, which are sensitivity report, which it shows also in one side. So these two combined together in a report gives you an antibiogram. So there are different types of antibiogram. One is the patient specific, which is individualized to the patient. Other one is a cumulative antibiogram, which sticks to the hospital, or it could be regional as well. Who makes these guidelines? Who creates these standards for setting these antibiograms? So standards in the sense, like all these antibiograms, as already discussed, it will have breakpoints, which is MIC values or minimum inhibitory concentration values. So these breakpoints, when a sample reaches a lab, how do you make it into stock solution? Which media you put it into, and how do you which antibiotic discs you put into, and how do you find out what is the minimum inhibitory concentration? Or if it's in a hospital which does not have latest technology, they may be using the inhibition zone diameters as the breakpoints. So who sets these standards? So there are two organizations which sets these standards. One is the CLSI. These are from this is a US organization, and this sets standards. They get approval from FDA, and they publish their reports when they send the drug leaflets. So I have one report on my left side. This is the M100. So this report actually briefs you about, it gives you update. It is an annual update. It keeps updating the breakpoints. How do you do the tests? How do you create the media solution? All these things. Again, it also for a lab which does not have technologies, they also have updates on the inhibition of zone diameters with disk diffusion method. So this M100, this is the 30th edition, and they do it annually. They keep updating, and this one is the 2020 version. An online version is available, which you can have a look, which is free, but the printed one, you'll have to pay for it as a package. The one on the right side, that is M39A4. This version is 2014, and this is used to create set guidelines for how to create a cumulative antibiogram. So as I told you, you have two types. One is patient specific, which most of you might have come across when you practice in the hospital, which you see. And the other one is there's a cumulative one, which is usually, it could be institutional or it could be regional. So it could be a couple of hospitals together in the region preparing one antibiogram. So who sets standards for this is CLSI. They have the M39A4, which is the updated one, which was in 2014. A new working group has been sitting on the latest one. So the draft has been set on 2019. Hopefully 2020 or 21, it should be out for the standards. So what is the use of this cumulative antibiogram? These cumulative antibiograms, the purpose of using it is to guide a physician to choose the empirical treatment. Also, it gives you an idea of resistance. So the next one is the breakpoints. So breakpoints, the MIC values, and they have CLSI also produces the breakpoints. Plus, there's another society organization which is European, run by the European Union, which is the UCAST. They also set breakpoints and guidelines. They keep updating it on regular basis, on annual basis as well. So what is the difference between UCAST and the CLSI? The worldwide, most of the hospitals follow the CLSI. But what are the differences, just to get to know? So as I told you, from the sample which comes into the microbiology lab, they actually prepare stock solutions. They create mediums in which they have to test the growth, and they also have antibiotic disc with certain concentrations. So all these have slight differences with UCAST and CLSI. Not much, but slight. And the MIC breakpoints for UCAST and CLSI differ. So it's not much, but still a little bit of difference is there. And how they report the microbiology antibiogram is also different. Okay. The CLSI, they report it as a susceptible, intermediate, resistant, or susceptible dose dependent, SDD. UCAST, they actually only have two types of reporting, that is susceptible or the resistant. These are the difference between the UCAST, CLSI. Mostly these are worldwide, the CLSI is followed, which is FDA approved. And when they bring breakpoints, the FDA approves the guidelines. So can I have the next slide, please? Okay, so just quickly, before we go on to selective reporting, let's look into the left side where you have a specific antibiogram for an E. coli for urinary tract infection. So after that, we'll discuss the selective reporting. So when you see this antibiogram in your clinical practice, first thing you need to think about is this really a pathogen or a colonizer or contaminant? Do you really need to treat this antibiogram or not? First question should be that. Rather than just jumping onto the antibiogram and treating the patient, you need to think if it's a pathogen or a colonizer or contaminant. Think of patient like flora, normal skin flora is staph epidermidis, or you may even have when it's okay. So if when the skin sample or the blood culture is not taken properly, they may cause contaminants which turn out to be positive in the culture. So just to avoid that, first thing you need to think about first is pathogen, colonizer, or contaminant. If the patient is symptomatic, definitely it warrants treatment. So next step is, if it warrants treatment, how do you go ahead? So first thing is you look for the site of infection. Where is the infection? If you can see urine, blood, or where it is, because it is important, because depending upon the penetration of the antibiotic, you'll have to choose an antibiotic. And again, you'll have to look at what organism is isolated and is the colony count significant. So you can see 10 to the power 5 is a significant colony count. It could be lesser, and it could be contaminant or a colonizer. So you'll have to even look at these parameters before you choose. So if once you look at all these, you confirm, let's choose an antibiotic, then it comes to the MIC breakpoints and whether it is resistant or susceptible. And how you choose an antibiotic is very important. When you see this culture, you have to go by the antibiotic which has the narrowest spectrum, lesser side effects. And the Penetration to the site also should be there. Without penetration, it may not be effective. Again, you'll have to also apply the PKPD into action. So think about an antibiotic which is narrow, because if it's broader, you're again causing collateral damage. Lesser side effects in the sense, you think of an antibiotic which causes QT prolongation, or causes C. diff, like clindamycin. It is causing a side effect which is unnecessary at this treatment time, and you may have other options as well to think about. Again, all antibiotics do not penetrate equally everywhere. You think about meningitis, piperacillin tazobactam do not have any penetration to the brain. Apart from that, the ceftriaxone, cefepime, these antibiotics have penetration. So you need to think in that way as well: penetration and concentration in urine. Not all the antibiotics concentrate in urine. Only if the antibiotic is concentrated in urine, it is effective. Once you come to all these parameters, next you will have to look at the MIC values. Why the MIC, understanding the MIC value as a clinical pharmacist, it's important is so if based on the MIC value, you'll have to either go up on a lower dose or a higher dose, or increase the frequency accordingly. So these are few things when you look at the patient specific antibiogram you need to decide upon. And like talking about stewardship, selective reporting, you can see the one on the left, it has all the antibiotics in it. While you can see the one on the right, it has specific or selected antibiotics. It is because it's just to prevent a physician from getting misguided and doing wrong antibiotic, rather than going for the narrowest one, which has more concentration specifically to urine. As a clinical pharmacist, you need to understand, sit together with microbiologists to set selective reporting, so that you understand the culture, you teach the physicians why you do like this, and you have to understand what is beyond this culture as well, why the other part of the culture is not reported. Can I have the next slide, please? So, okay, so this is cascade reporting. This is a different way in which you keep aside the second line antibiotics or broad spectrum antibiotics without reporting. So you only report when the primary antibiotic is resistant. If the primary is not resistant, you only report those. So you can see an example. If the antibiotics gentamicin is resistant, you report tobramycin or amikacin. Ampicillin is resistant, you report amoxiclav or piperacillin tazobactam. So if this is not resistant, you only put a sensitive to ampicillin or sensitive to gentamicin. You don't report the remaining, as shown in the previous slide, because it's just to avoid misguiding a physician from ordering a higher or a broader spectrum antibiotic or a costly antibiotic. Can I have the next slide, please? Okay, so this is, so first part we dealt is about patient-specific antibiogram. Coming on to a cumulative antibiogram, this is an institutional antibiogram which has been used to guide a physician to order empirical antibiotics or to see the resistance pattern. So as I told you, the CLSI produces guidelines which tends you to create these antibiograms. So what are those guidelines? So they say at least 30 isolates should be there, and it should be diagnostic isolates. It should not be surveillance isolates. Always report if you have a patient with multiple organisms in one culture, you report the first isolate. All these are few guidelines which have been mentioned by the CLSI. Again, this report can be produced by the hospital on annual basis or biannual basis based on the isolates which can be brought out. Again, can be done classified antibiotic wise and site wise as well, which makes it more important. Supplemental analysis reports can also be added. Like in this same report, you can also add, like for example, strep pneumonia. You can add the meningitis as well as non-meningitis susceptibility as well, because it's different. So these are few things which you have to look into when you look for a cumulative antibiogram. So let's go on through this report, which is a sample report, how you choose. To know your community, to know your hospital, and to know your ICU is equally important to choose an antibiotic. Think just go on through, like if you look at the top, you have antibiotics. On the left side, you have the organisms. You can see OP in green is outpatient, IP is inpatient, and ICU is in red. So let's look about the E. coli, which is in green, which shows it, the outpatient treatment, the nitrofurantoin is sensitive. So you, based on this susceptibility report, you actually choose the one which I already discussed before. all those narrow spectrum, lesser side effects, most cost effective, and it has to be at your choice should be more than an antibiotic which has more than 80% sensitivity. So on this, the narrowest one and the less costly and the lesser side effects one would be nitrofurantoin. Again, depends upon the patient and where the site of infection is. So this is how you go by the antibiogram for choosing the treatment for outpatient. Suppose the same patient has urinary tract infection in the hospital, admitted, but not in ICU, but in the wards. You have three choices. I have marked cefzalbactam, amikacin, and piperacillin-tazobactam. Again, urinary tract infection, you have to look for two things. Is it cystitis or is it pyelonephritis? Again, you have to choose the one which is more than 80%, that is better. So if it's cystitis, I would actually go for amikacin, that is 90%. Cystitis is lower urinary tract infection, which includes the bladder. Pyelonephritis is upper urinary tract infection, which includes the kidneys. So if it's pyelonephritis, my choice would be piperacillin-tazobactam. Again, I would be choosing the best antibiotic out of all these, and which is more than 80%, and considering multiple factors, which includes patients, as well as the cost and side effects caused by the antibiotic and the spectrum. If the same patient is in the ICU, septic shock, after maybe say a week of ICU stay, develops urinary tract infection, I'll have to think of something higher, because based on the resistant pattern, I can see my ICU flora looks sensitive to meropenem. I would actually go for that rather than keeping on tazobactam or cefzalbactam and then come down. Again, it's very important. You'll have to set guidelines rather than going for all the patients choosing meropenem if the patient's septic shock. There should be guidelines based on the site of infection. That is also very important. Coming on to the Klebsiella pneumoniae, you can see I just rounded the colistin. So colistin is also getting resistant in the hospital and as well as the ICU. So it's equally important how you choose the antibiotic and how you judiciously use the antibiotic. When you come to the Pseudomonas cover, you can see I've rounded ceftazidime and cefepime. It's just going by. So both of these antibiotics have similar spectrum and cover Pseudomonas. So what I would actually do is I would actually keep ceftazidime as a reserve, because you have so many other higher antibiotics which are related to ceftazidime, and I would choose cefepime because considering to avoid any resistance to ceftazidime. Again, ceftazidime, you can keep it as reserve to use for like mucoid Pseudomonas or Stenotrophomonas. All these organisms, you can use ceftazidime, but not for all the Pseudomonas or not for any other infection I'll be using. But those will be stewardship practices which I would actually follow based on my antibiogram. Now, next one would be the Acinetobacter. You can see the ones in red only sensitive to colistin. That is something which is concerning. So you can see 80% means that the remaining 20 is resistant. In patient, you can see 100% sensitivity, but still it is a concerning factor, because you can see the remaining antibiotics, the sensitivity is not that great, and you won't be able to use that. You'll be ending up in harming the patient or causing higher mortality, because you're literally running out of antibiotics. So can I have the next slide, please? Okay, so as I talk about stewardship, so previous slides of stewardship were diagnostic stewardships, where you actually collaborate with the microbiologist. You understand the importance of collaborating with microbiologist and knowing the antibiogram in a better way. Now it's a broader teamwork, which has to be starting with the pharmacy. So formulary management and restricted antibiotic policy. These are few things which you have to set it up in the pharmacy level. A role of clinical pharmacist comes in where you actually restrict the antibiotics from coming into the formulary. Like suppose, for example, I told you carbapenems. You don't have to keep all the carbapenems in the formulary. You can actually keep meropenem, ertapenem, while the spectrum of others are also kind of similar. And as I told you, cefepime, ceftazidime, you can actually keep cefepime as your first choice for treatment. Ceftazidime restricted to mucoid Pseudomonas or Stenotrophomonas or for cystic fibrosis patients. Again, formulary management by a pharmacist, it's important you review and remove the weird antibiotic combinations. You avoid any duplicates or multiple brands, or you use generic antibiotics. These are very important when you set formulary management. And again, you have to keep a set of antibiotics for restricted policy as well, which should not be ordered or misused inappropriately. Coming on to the formation of antibiotic stewardship committee, this committee actually includes a team of ID physician, a pharmacist trained in ID, or it could be a learning pharmacist as well, a microbiologist, a nurse who could be an infection control nurse. Administration should also be there, the administrative staff, because they are the ones who help you set policies and circulate. Again, you need an IT team as well who sends out emails or sets it up for you so that you can share with the other physicians as well. This team together, they either form clinical guidelines for the institution or review the existing ones. They keep updating it. They review the policies, create policies, procedures, or protocols, which make it more better and use your resources in a rational way. Like for examples of protocols, like Sir has already mentioned procalcitonin. You need to use this marker judiciously. It's a costly marker. Unnecessary usage will end up cost, and it does not guide you or give you any response or anything. So it's very important that you set a protocol for an example, like you set a protocol for procalcitonin so that you use it where you actually need it for de-escalation, and you don't misuse it. Another one is the urine culture ordering. These are examples of how you can form and where you can focus upon. Urine culture ordering, like suppose a patient's most commonly over-treated infection is urinary tract infection. Most of the patients may have asymptomatic bacteria, which does not need treatment. Again, when you have a urine analysis with bacteria positive or nitrite positive, it tends a person to send a culture analysis, which may not be needed because the patient's asymptomatic. When you have a culture with you, you think of an E. coli 10 to the power of 5 colonies, you have it's the intention to treat it, which is again unnecessary because it is a patient's asymptomatic. So all these can be avoided by setting a urine culture ordering protocol, which will be beneficial. Again, prolonged or continuous infusion protocol for antibiotics. This is specifically, it takes a lot of strain in nursing as well as a lot of money and incompatibility issues as well. So this should be restricted to ICU. Again, not all the patients in the ICU. You have to choose the patient for whom the PKPD works well for the infusions, prolonged infusions. Another simple way in which you can use the antibiotics is IV to oral switch. If the patient is actually eligible for IV to oral switch, where a patient's tolerating feeds properly, taking orally properly, then you can actually, infection settling down, you don't have an infection, patient's currently fine for previous 48 hours. You can actually switch the patient from IV to oral. It could be with an agent which has equal bioavailability, like 100% IV oral, or a similar one which could be almost equivalent. So these are few sets of protocol which could be done in the institution level. Coming on, you have to measure to know how you're doing good. So a couple of measures are like you measure the process, how the process, are the physicians working properly, are working out on the policies and protocols properly, ordering the antibiotics rationally, are the labs coming out properly, are the pharmacists catching these. So these are all process measures. Again, outcome measures in terms of patient mortality, length of stay, all these are outcome measures. Another way which is easy for measuring is the antibiotic consumption metrics. There are two metrics which can be commonly used. One is the defined daily dosing, which is actually a WHO set protocol metric. It can be, the formula is actually, you actually calculate the grams or units of antibiotics divided by a WHO defined DDD value, the whole divided by the number of patient days into 1,000. These formulas are all available in the website, so it's easy for you to go about and look at it. So again, that is one marker. Other marker is the days of therapy per 1,000 patient days. So how do you calculate this? Is you actually calculate the number of days a patient is getting an antibiotic. Suppose two patients getting two different antibiotics or two similar antibiotics for 5 days. So that makes 5 plus 5 makes it 10. So that number of days divided by the total patient days into 1,000 makes the value. So remember, the first one is based on grams or units. You calculate the whole total dose the patient received. Again, it does. So the defects of that one is like if the patient has renal doses or if it's pediatric, that causes confusion. So mostly the DOT is one which is followed. Again, these are the formulas, and the number of patient days, how it is calculated, that is actually an administrative value which you can get from the institution administration. It is the number of patient days equals to the number of admissions during a time frame. That is, consider month of April, how many patients with infection got admitted, and what is the into the average length of stay. This is the formula which is used for calculating the number of patient days. This is quite a common formula which is used by infection control to calculate the rate of VAP or hospital acquired pneumonia or COTI. Next one is pre-authorization. So you'll have to restrict your antibiotics very wisely. So to know that, you'll have to actually put restrictions in such a way that an ID has to consult, a physician has to consult an ID, physician or ID trained pharmacist before they initiate a treatment with restricted antibiotics. It could be, if it's off business hours, they can actually go give the first dose. Beyond the first dose needs a consult. Or if it's something which is lesser causing harm, you can actually keep it for 3 days. Beyond 3 days to continue that antibiotic needs a consult. Another way in which you can actually use the reserved manpower, that is our interns or students, is like post-prescription review or feedback. This two things. One, if you have an institution with lesser patients, adequate number of clinical pharmacists, they can do it themselves. If your hospital is actually very huge, where you can't, one clinical pharmacist or the set of clinical pharmacists can't reach all the patients for reviewing the antibiogram or the antibiotics, you can set or empower our interns or students, give them a little bit of training, and ask them to look at the antibiotics used in the hospital. Again, these could be wrong, could be right, but they actually learn from that, and you actually will be able to reach all the patients who are on antibiotics. This can be actually set from a report from pharmacy, which actually gives you a set of antibiotics which is commonly used and where the patient is located. Or you can actually pull out the reports from the lab and say that this patient is in this floor, let's review that floor. So like that, you can actually set up ways in which you can pull the reports from the pharmacy or from the microbiology lab. In a system where you have electronic medical records, the duration of therapy, you can actually add smart stops or timeout alerts just to prevent the overuse or like over treating a patient. So a physician will be able to review, it gives an alert to the physician, and they ask them to review the antibiotic order and ask them whether this therapy has to be continued or not. So these are few things which could be applicable for the electronic medical records. Coming on to rapid diagnostics, these are important. Like pharmacist also knows how rapid diagnostics are done, what are the technologies available, and how to de-escalate and how to escalate. Suppose, for example, you have a MEC-A gene when the patient's on vancomycin, it's a staph aureus. If it's negative, MEC-A gene is negative, you actually can come down from vancomycin to something which is lower. And these are few things the pharmacist has to know how rapid diagnostic works, and the few hints and clues which that gives you helps you to utilize antibiotics rationally. Can I have the next slide, please? Okay, so these are few sets of stewardship practices which I pulled out from these three references. These three references are the best and has more information there. So I would actually these are all free, available online. I would actually recommend you to go and have a look at these, because it gives you better information and more information, interactive ones, which would be helpful for you to practice future as well. Can I have the next slide, please? Okay, so the last slide for the day is newer antibiotics. So remember, the newer antibiotics is our reserve force. This is actually restricted. Make sure that you don't actually misuse it unnecessarily, so that it ends up to cause collateral damage or you end up running out of antibiotics. So quickly going through the ones which are listed here, I would actually quickly tell you the doses where it's used and when you have to really use it. So ceftriaxone tazobactam, this is specifically to treat the Pseudomonas species. This combination overcomes the resistant mechanism of efflux pump, and it also has stability against the AMC resistance of the Pseudomonas. This is actually a choice for ceftriaxone tazobactam. The choice when you run out of antibiotics, it is colistin resistant Pseudomonas. You actually put in this antibiotic, you actually see if it's sensitive, then you use this. This ceftriaxone tazobactam is actually a modified side chain of ceftazidime, and so that is why I've actually previously mentioned how to judiciously use ceftazidime as well. The dosing of ceftriaxone tazobactam, you can actually do 1.5 grams Q8 hours for intra-abdominal infection or for urinary tract infection. You can do a dose of 3 grams Q8 hours for a hospital-acquired infection or for ventilator-acquired hospital-acquired pneumonia or ventilator-acquired pneumonia. It's usually infused over 1 hour. The next class is the next antibiotic is the ceftazidime avibactam. This combination is actually preferably used for the KPC oxa 48 and these types of resistant, as well as it actually specifically covers the AMC types of resistance for Pseudomonas. So the important thing is when you use these antibiotics, you need to know what are the different mechanisms of resistance of bugs in your hospital or in your community, because it's equally or in your ICU, because it's equally important. Without knowing the types of mechanisms of resistance, you actually try to overuse it or unnecessarily stock them in your pharmacy. Specifically, ceftazidime avibactam, it's for OXA48 KPC type of resistance, AMC producing Pseudomonas as well. The dose would be dose of ceftazidime avibactam would be a 2.5 Q8, and it's usually infused over 2 hours. And usually ceftriaxone, tazobactam, ceftazidime avibactam, these combinations do not cover the NDM strains, do not cover MRSA, no anaerobic coverage, and no enterococcus coverage. Coming on to the next one is the meropenem vaporobactam. So so some of them are available in India, some of them are on the pipeline, would be released shortly. So this is just not to complicate, it's just to make sure that you understand why these have to be used judiciously. The meropenem vaporobactam is actually, it covers the KPC and the AMC type of KPC and the AMC resistance in Pseudomonas. The dose is usually 4 grams Q8, and it's infused over 3 hours. So it has 2 grams of meropenem and 2 grams of vaporobactam as well. In the previously ceftazidime avibactam, in 2.5 grams, you have 2 grams ceftazidime and a 0.5 gram of avibactam. Ceftriaxone, tazobactam, it's usually 1:1.5 ratio. If it's 1.5 grams, 1 gram of ceftriaxone and 0.5 of tazobactam. If it's 3 grams, 2 grams of ceftriaxone and 1 gram of tazobactam. Coming on to imipenem relibactam, this combination is actually used for, again, it is used for AMC Pseudomonas, it's used for KPC, and it's also used for efflux pump mechanism of Pseudomonas as well. The dose is usually 1.25 grams every 6 hours over 30 minutes infusion. Again, it has 1 gram of imipenem cilastatin and 0.25 grams of relibactam in this combination. Aztreonam avibactam, this is actually in the pipeline, not available as such. So what this is actually a drug which you use to avoid the combination of ceftriaxone avibactam. So Aztreonam avibactam is not in it's not in the market, it's just in the pipeline. So instead, we actually use Aztreonam with ceftazidime avibactam combination just to get a better coverage in terms of NDM. So NDM strain of Enterobacteriaceae is covered by Aztreonam plus ceftazidime avibactam. Remember, these antibiotics are used when the patient is resistant to colistin or you don't have any other option. So it's not an alternative, or it could be, again, it depends upon case basis as well. So it does not mean only for these. It again depends upon case basis and availability. Next, 2 antibiotics, the plasmomycin. It's actually add-on therapy to the existing one. It is an aminoglycoside class of antibiotics. It is usually used for urinary tract infection where the other aminoglycosides are resistant. Again, it is used for OXA48 and KPC as well. So the dose is usually 15 milligrams per kg per day dosing. Again, you need to do renal TDM monitoring as well. Other antibiotics and all of these, you have to actually look for the renal dosing as well. Cefiderocol, this is an antibiotic which specifically treats the Acinetobacter strains. It actually has spectrum for almost all, but you actually use it, you keep it for Acinetobacter because of the broad spectrum, and you don't use it for others because you actually want it to be reserved for the Acinetobacter as well. So the Cefiderol, it's a recent one which got approved, FDA approval on November 2019. The dose is usually 2 grams Q6 or 2 grams Q8. It is usually infused over 3 hours. These are newer antibiotics which has to be restricted, reserved. Remember, use of these should be judicious. Unnecessarily, this should not be coming into the formulary. These are to be used when patient really needs these, when other options are not there, most of them colistin resistant, and the plasmomycin only for a combination therapy as well. Thank you.
Thank you, Dr. Hisham. It was an excellent presentation and taking us through the entire antimicrobial stewardship program, starting from the antibiogram, that is how to prepare an antibiogram, an antibiotic policy, the team, and the antimicrobial stewardship program, monitoring your antimicrobial stewardship program itself, and then taking into the newer agents or newer antibiotics which are in the pipeline and those which are approved to be used. Like they always say, this I think it was by Dennis Mackey in 1998. He said the development of a newer antibiotic without having a mechanism of its appropriate use or ensuring its appropriate use is almost like supplying your alcoholic patients finer brandy. That's all. Okay, it's as similar to that. So it is very important that we understand preparing antibiotics against gram negative is difficult, and it is not going to come up as a newer compound in the near future, as you would see. So preserving the antibiotics in hand is the key, and the role of the clinical pharmacist is most crucial in a team that decides on the antibiotics and therapy using antibiotics. So in the stewardship team itself, the role of the clinical pharmacist is the key. All right. So today's session, we have looked into the sepsis, gram negative sepsis, okay, how these gram negative sepsis can lead to severe mortality and how they become the problem in your ICUs, the scores or the SOFA scores which we use to identify them or categorize them in choosing patients to start them early therapy. Then looking at the organisms that cause these, the gram negative organisms that are associated with these kind of sepsis. Why is the difference between the gram positive and gram negative? And what are the various resistance that you would see with them? How do you recognize these resistance? How do you identify the organism causing these infections by itself? By a conventional routine methods and also by biomarkers that we use? And what are the antibiotics that we can choose in treating these patients based on our local antibiogram or our local flora? So knowing the local flora is important so that you identify empirical antibiotics which you choose to use before your reports come in place. Therefore, sending a sample before you start an antibiotic is important. So is important is starting an appropriate antibiotic at the time so that you save the patient's life in the long run. So therefore, here is the role of the clinical pharmacist, which is crucial, and understanding the antibiotics that are available to us, knowing the PK/PDs of these antibiotics, and knowing which antibiotic to choose on which organism and the types of resistance within that particular organism, and our antibiotics which can be used in combinations was very well described. And then looking at these antibiotics that we already have, how to judiciously use these antibiotics was described again as an antimicrobial stewardship program on forming a committee, the role of a clinical pharmacist in the committee, the importance of restricting the antibiotics, making it available only those which you would want to use. The others are being restricted, not totally restricted, but restricted depending on its use and authorized only. So you require something called as pre-authorization. And then doing an audit and see what are the antibiotics, which are the situations that these antibiotics are being used, and looking at the DDDs and the DOTs, and giving a feedback to the treating team or the clinical team. All of these form a very important aspect where the clinical pharmacists play a role in the treatment of a patient with sepsis in an ICU. As we come to the end, I would like to thank all the panelists who did an excellent job. We did exceed a little bit of a time, but I think this is one of the best seminars or the webinar that we've had in the long run, because this is one it is non-COVID, because we're tired of hearing COVID seminars, and this is a non-COVID seminar which has excellent speakers who spoke with clarity and simplified the concepts and put it very clearly to all of you to understand, right? With that, I would also take this opportunity to tell some take-home points. There are only two that I would want to say. One is it's important to have the right drug for the right bug at the right time to save your patients with sepsis or suspected sepsis. And the role of the clinical pharmacist is crucial. Like what I said you from the beginning, your role is very, very crucial in treating these patients. And please understand, in the developed countries, like what Hisham was telling, so those are very well established. These practices are happening day in and day out. And his thoughts and guidelines, whatever he shared, is easy for us to implement in our own settings if we have not done so far. Okay, and it is important that we use the antibiotics judiciously, and we do not allow inappropriate use of antibiotics. In both of these, the role of a clinical pharmacist is crucial. With that, we thank the entire team of participants who've registered in large numbers to listen to this particular seminar and to be part of it. And a big thanks to all of the panelists who brilliantly presented their piece of work with, in a sequence that anybody would understand with so much of clarity. Thank you very much. However, there are some overwhelming responses in terms of questions, right? So I would just ask the organizers if we can just take one question for each panelist. The rest of the questions maybe put up and shared in a format, maybe in an Excel format. The panelists can answer your questions and share it with you personally, all right? Or maybe to the group, okay, which is possible because there are about some 26 to 30 questions. But when I look through the questions, many of them have been already answered. Okay, many of the questions that was raised in the initial part of the session have already been answered by the speakers through the session. So I will just ask each panelist one question, whichever has come up, which was not maybe addressed or has been a practical issue only. Joseph, sir, there is a question for you. They say, how do you identify and how do you handle a pregnant women with sepsis? How do you, pregnant women?
Pregnancy and sepsis has a different score because the pathophysiological parameters are quite different. They have a different scoring system, that is the SOS scoring system. It could be found out in the net, but then all this sepsis being an immunocompromised state, these patients have to be treated very aggressively. The same sepsis guidelines hold true for treating sepsis in pregnancy, but the medications have to be judiciously used, should have a wide spectrum coverage, and as of now, the current guidelines say that there is no difference in treating sepsis in pregnancy as compared to the normal individual who would develop sepsis. But there will be many pros and cons for this. But as of now, as per the current guidelines, this holds true. Whether the current sepsis guidelines provides a framework for further development of our understanding of sepsis in pregnancy, and whether they'll be considered a separate entity in future, only time can tell with further research and work going on.
Thank you very much, sir. Thank you very much, sir. I'm sure the participant who asked this question is satisfied, and this is the most clearest way of describing and responding to your question. Dr. Jency, there's a question for you on the use of MICs. Okay, they just want to understand. Here is a basic question on, does the MIC change between patient to patient? Are the MICs going to be changing between patient to patient? And I'm sure you all understand as clinical pharmacists, the MIC is going to be for the organism. So therefore, there may not be a change from patient on looking at patient to patient. It would be from organism to organism itself. And therefore, being isolated in a patient, it would change from one patient to another on the MIC. Over to you, Dr. Jency, on telling them on the use of MIC in choosing the antibiotic.
So like Grace had pointed out, when you choose the antibiotics, you will look at the MICs. So if you have various antibiotics in front of you, one is you would use the hospital antibiogram. So if you have few antibiotics on this, you would know for this set of organisms, this is what you're going to use. And in that, when you look at the MIC, the least MIC, that is what you would like to choose. Because you know that when MIC is low, that means this is the least resistant one. But sometimes, even if MIC is high, if you don't have anything else on board, you may still have to use that antibiotic at a higher dose to combat, or maybe use as a synergy with some other antibiotic to use that. So MIC, like ma'am rightly pointed out, it doesn't vary from patient to patient. It varies from that inoculum which has come, that organism which has cultured, that may have a different MIC.
Thank you, Jency. Um, Dr. Grace, there are questions for you which were already answered by Hisham on the role of ceftazidime with the avibactam. I think that was dealt in depth. But they had one other question on the difference between colistin and polymyxin and its use. Do you have anything for that?
Yeah, actually, polymyxin B and colistin is basically polymyxin E. So if you see the major difference that we use is that for polymyxin B, the nephrotoxicity is much lower than colistin, and we prefer to use polymyxin B for patients who are having like kind of kidney injury or CKD, and also polymyxin B is colistin is a pro drug, but polymyxin B is not. So colistin once it enters the body, it has to become the active drug to because we normally give it as colistin sodium, so it has to convert to colistin for its benefit. So and therefore polymyxin B in a way has a more stable pharmacokinetics than colistin, and therefore the values won't fluctuate much. These are the proposed thing. And also the one other thing I would like to point out is that for urinary tract infections, you don't give polymyxin B because it won't get concentrated well in the urinary tract, but instead you can use colistin. So these are the major differences between colistin and polymyxin B.
Thanks, Dr. Grace. I think that would answer the question to the participant. Here we have the last one for Hisham. For all the young clinical pharmacists, all of them looking at ID clinical pharmacist as their career, there is something that I would ask for, and I think would want you to share with them. What are the challenges a clinical pharmacist face when establishing or running an antimicrobial stewardship program, and how did you overcome that? So I just want you to say and share with the clinical pharmacists what are the common challenges that you face as a clinical pharmacist in handling or in doing an antimicrobial stewardship program in any settings. Okay, so what did you face and how did you overcome, and what do you think are the other challenges that they may face and how they could overcome that?
I would be actually sharing my experience from when I was working in India, where I actually was a part of the stewardship team, which created the guidelines for the hospital in Coimbatore, KMCH. So the few things which I would actually would like to share is you actually start with building your knowledge towards antibiotics and knowing a general microbiology and how you can implement it in a hospital setting. You actually have to collaborate with the physicians who are actually would be the part of this team, a microbiologist. I actually went myself into the microbiology lab. I sat there for a few days. I actually learned from the microbiologist what each of these things from them. Again, a physician's part as well. I actually did rounds with the physicians, and you actually get to know each patient how and when and how to interpret the antibiogram and how to share. Along with that, a lot of reading is needed. So it's all the foundation is knowledge. Second is collaboration with the team. It includes microbiologists, ID physicians, or people who are trained in ID. Again, a lot of reading, which is a commitment from your side, is also important. You put all these together, you actually can practice by working together in this team and implementing things as well. So you actually don't do everything in one set. You actually start slow, you go smoothly, and Rome was not built in one day. So it actually takes time. So you actually go slow, you actually learn, you actually implement as you go on, and you actually set it up in such a way. Then I actually start from scratch. So you actually can start from scratch. You can implement it throughout as you go on, and step by step. And you have to get the help of the administration as well to get it implemented throughout the hospital as well. So these are a few things that I would actually recommend the budding pharmacist or interns. Nothing happened in one day. You actually start from scratch. How you start from scratch is building knowledge, building relationships, collaboration, reading yourself, updating your knowledge, and implementing it together as a team.
Excellent, excellent. I think that's the best way to end the note. I could share the same one when I was handling the team in my hospital to set up an antimicrobial stewardship program. Similar challenges, and I found that the clinical pharmacist, like what Hisham was mentioning, I had used for the last 4 5 years. I've been using the clinical pharmacists, the interns, where they are posted for a month with me, and then we asked them to go on rounds, and I had specified set of things for them to do and capture. And so the monitoring was easy, the auditing was easy. They understood what was happening, and giving a feedback was structured. And we weren't missing any of the areas, though we had focused on few things, but those were done incomplete, and it could be extrapolated into the practice across the hospital, and that was fantastically well. But it took, like what Hisham was telling, not happen in a day or two. We had failed many times before we could even establish some part of it. Even now, there are some things which we have failed, in so some systems that we have failed, but we continue to strive to get, to the best of our ability into doing the best of practices in preserving the antibiotics that we have in hand. Yeah, with that note, thank you very much for an excellent 2 hours that we had. I think, like we all said, we overshoot time, but we did a fantastic job. Excellent team of panelists. Thank you, panelists. You made the whole program do well. Thank you very much.
Thank you, ma'am. With that, we've come to the end of a 2 hour session, as ma'am mentioned. It was indeed a long, exhaustive, but extremely informative session. We had quite a few participants joining in. So let me thank the moderator, the panelists. Let me extend my thanks to the clinical pharmacy department at Believers Church Medical College Hospital, also the technical wing that supported us. This webinar is going to be there on the official YouTube channel of the hospital, of the Believers Church Medical College Hospital. We've been able to take a few questions. The rest of the questions we try to answer as against the questions on the comment section of the YouTube video. We're going to leave a YouTube feedback link. That link will be available on the Zoom channel, on the Zoom chat box, as well as the YouTube channel. So thank you all. Thank you all for joining. We hope to see you with more academic programs in future. Stay safe. And thank you so much.
Thank you. Thank you very much. Thanks all. Thanks, participants. Thanks, the panelists. Thanks, Dr. Sumita, for a wonderful coordination. Thank you.